Welcome all back to the sessions again. And I again thank the organizers and Sir for inviting me to talk on this very interesting topic. We just heard Dr. Sonia Malik ma'am say that third-party reproduction is difficult, could be difficult. So we have to look at ways forward for looking at that. So possibly this is what we are looking at for our women. And when Dr. Roy Homburg said famously, like decade ago, that probably oocyte freezing, oocyte vitrification is women's emancipation set in stone, this is probably what he was foreseeing as what we might be needing. So why are we talking about social oocyte freezing or elective egg oocyte freezing? Because A, women are pursuing fertility at an advanced age. Family planning and sexual education have traditionally focused on contraception prevention of sexually transmitted diseases, but now the focus should also be placed on fertility awareness and fertility preservation. When we are talking about postponing fertility, this is another aspect that we must be talking to our patients. We do know that there is an age-related decline in the female reproductive potential, which is inevitable and irreversible. Age confers a bi-exponential decline in the quality of oocytes, especially after the age of 37. The egg quality and chromosomal integrity of the resulting embryos are affected after the age of 35. And advanced maternal age is an important risk factor for early miscarriage, and age-related miscarriage rates between 51% and 40 to 44 being 93% after the age of 45. So now, coming back, the success rates after one cycle of IVF reported around 30% for the women below 35, but this percentage drastically decreases almost to no chance of live birth rate above the age of 45 when the woman chooses to use her own eggs. So options such as, we've been using donor oocyte or adoption has been in foray now. With the advent of the ART law in India and difficulty in getting donor eggs, and there are lots of women for which either use of donor eggs or adoption is not acceptable and wish to have genetically linked offspring, age could be a barrier, and here comes the role of fertility preservation electively when we are talking about contraception for the same when the woman comes to us. So we have just looked at the science. The logic here is that the success rate is better with younger eggs rather than when we use the older eggs. That means the eggs when we retrieve after the age of 35 or more. And there is definitely a lack of awareness in women of reproductive age around what this treatment involves and how to access it, what is caused, what are the possible implications, and definitely the success rate. This is not the lack of awareness only for patients. I think there is also less awareness among doctors themselves in regard to this. So that is something we should be looking at. So is what we call social egg freezing the right term? It may not be the right term to use. It probably elective oocyte freezing or oocyte banking for anticipated gamete exhaustion, or Eschrey termed it oocyte cryopreservation for age-related fertility loss. These could be the way forward for using those terms, and social egg freezing does not seem to imply what we are trying to do. Is there a demand? Okay, for example, in India, we don't see that much, but yes, there are women coming to us more, but yes, there has been an increase in demand, and egg cryopreservation has been one of the fastest growing fertility treatments in the UK, increasing by 10% every year, and 240% increase between 2013 to 2018. In Spain, egg freezing cycles for fertility cryopreservation increased from 4% of the total vitrification procedures to 22% in a 10-year period. Similarly, in USA, fertility preservation cycles increased from 9,000 and odd to 13,000 and odd in 1 year. So these are all the papers. I'm sorry for this very busy slide, but I just wanted to show you so much of publications has been made. But what I wish to for us to concentrate here is on the survival rate. The survival rate of the oocytes has been good pretty much, but there are varied pregnancy rates, that ongoing pregnancy rate per, or the live birth rate in different groups. But approximately it is when the ages are less than 35, it is usually pretty good. About, it ranges to the tune of about 40% to some to even 50 to 60%. So the first question that we all ask ourselves, and the patient is going to ask us, is how many oocytes do I have to freeze to have a good chance or a reasonable chance of having a live birth? Again, there's been many numbers, but I guess it varies between 10 to even 40 at less than 35. But as we see even here, when the age goes up, from the woman's age goes from 35 to 40, there is a huge increase in the number of eggs that we need to have a reasonable live birth rate. I think this also we can extrapolate that to our patients as well. So at less than 35, if we are looking at about 14 in Doyle's study, for him, he needs about 26. In his publication, there was about 26 oocytes, M2s, between the age of 38 and 40. There is nothing here after the age of 40. If it's about 10 at less than 35 years in Goldman's publication, he has mentioned that the number that he needs to have to counsel for a reasonable live birth rate at between the age of 30 to 40 is 61 M2s. Koba et al. Again has got about similar. So there is quite a varied number, but I guess definitely worth saving the oocytes at a younger age than going through multiple cycles at a later age. So at a benchmark, there has been a study which said that about 24 eggs frozen, M2s frozen, gives a good chance or a reasonable chance of live birth rate at a later age. So the return rate, that is what everybody keeps questioning on the ethical front, that, okay, you freeze eggs, but most of them never come back. No, it is just like having an insurance. Like, not all insurance we definitely need to use at some point of time, but it is a choice. But it is a choice that we need to give to women to make it, given all the counseling that we give them. The return rate has been abysmally low, but then still, has there been a regret among these women who have electively frozen their eggs at a younger age, and they did not come back to use their eggs, but instead they went ahead and have a spontaneous conception at a later stage? More than 95% did not express a regret. Instead, more women actually told where they were expressing regret that they were not counseled about this at an earlier age. So I guess it becomes that more than half of them actually conceive naturally, but it becomes a responsibility of the OB-GYN or the GP, whoever is talking to them about contraception, to even talk to them about this at a later stage. So again, there was even a publication on the awareness among that was imparted to these women. There was it was published that only a minority received regarding treatment from their gynecologist, and they would definitely, the women who had frozen their eggs would definitely recommend this to another person, because it gives that sense of probably like, okay, I can have something to fall back on. Okay, this is the science, and that is the psychological aspect of elective egg freezing. And what about the cost? Is it going to make it very expensive, that it's not going to be of any use? No, the cost effect ratio. There's been a very good study based on the SART, the SART data on the cost effectiveness of analysis of planned oocyte cryopreservation versus in vitro IVF with PGTA at a later age. For those desiring one live birth, when they had planned oocyte cryopreservation at the age of 33 and warmed those eggs frozen at the age of 33 at the age of 43, decreased the average total cost from 62,000 to 30,000 only, and increased the likelihood of a live birth from 50% to 73% when no oocyte cryopreservation was done. For those desiring 2 live birth, again, it was the same. 2 cycles at the age of 33 and warming at the age of 40 yielded a lower cost per patient and a highest likelihood of achieving 2 live birth when compared to 1 cycle of oocyte cryopreservation or no oocyte cryopreservation and IVF PGT with embryo banking, or no oocyte cryopreservation with IVF PGT-A without embryo banking at the age of 40. So that is just, I just put it because those 2 slides were pretty confusing even for me. So I just put it just to put in a tabular column for us to see easily. For with no oocyte cryopreservation, for 1 live birth, it cost about 33,000 USD with a pregnancy rate of about 73% as mentioned. Whereas with no oocyte cryopreservation, the cost was doubled and pregnancy rate was obviously lower. The same for 2 live birth, if the woman wishes to have 2 live birth. Hence, sensitivity analysis has repeatedly shown that elective oocyte cryopreservation at a younger age is definitely more cost effective than going for IVF with PGTA, even with embryo banking at an age, advanced maternal age. For 1 live birth, achieved the highest likelihood of success was when pursued before the age of 32 or 33. And for 2 live birth, 2 cycles of oocyte cryopreservation achieved the highest likelihood when pursued before the age of 31 and remain definitely more cost effective than IVF with PGTA when pursued after the age of 30 or 39. So it then comes to the issue. Now the law has here or in the USA allows us to freeze those eggs only for the period of 10 years. So if somebody freezes at the age of 28 and they want to go ahead at the age of 40, you don't have that, you've elapsed the storage years by 2 years. So that's something that we should be talking to the lawmakers to, while our law has given that concession to onco-fertility patients, they should also give this concession to women who have frozen those eggs for against age-related fertility decline. So with all this in hand, how do we counsel our patients? Yes, we have something built in our brain scientifically, but we still have to counsel them. We cannot, unfortunately, even with elective oocyte cryopreservation, even if you have 100 eggs, we do know that we can never guarantee a live birth for a patient. So there is insufficient evidence to counsel women about the likelihood of live birth after planned oocyte cryopreservation. It is recommended that oocyte cryopreservation be offered as an option to women in situations where there is unanticipated lack of sperm on the day of retrieval, or a desire to limit the number of fertilized embryos, or to counsel women that live births per embryo transfer are improved if oocyte cryopreservation is done at a much younger age than in older age. And there is insufficient data to advise women on the optimal age to undergo planned oocyte cryopreservation, because as we know, some even at the age of 28, their AMH is 0.2, 0.3. Well, while we are unable to put a cutoff, I think we have to go at individualistic, personalized for each of our patients. But as a thumb of rule, we can say below the age of 32 or 33 in a normal AMH person, normal responder, seems to be a good rule to take forward to. And there is also insufficient evidence to counsel women of various ages on the absolute number of oocytes. We must have to have a reasonable probability of live birth, but we can go with the publications about probably 24 to around 24 could be a reasonable number. Infertile women should be counseled that based on the small number of birth, neonate outcomes appear similar after using their own previously cryopreserved oocytes compared with the outcomes after the use of fresh oocytes. And there is also insufficient evidence to counsel patients regarding the likelihood of long-term use of oocyte cryopreservation. That is something we don't know, but as of now it's been fine, but we are yet to know what could happen 30 years, 40 years down the lane. The one thing that we always have to talk to them is that egg freezing is neither a guarantee of a live birth nor a panache for the various socio-economic, cultural, or emotional challenges which may lead women to defer parenthood. They also have to undergo the IVF treatment if they want to use the cryopreserved oocytes. And there's always the immediate risk of OHSs, egg collections, and other bleeding, infection, everything associated with the IVF procedures. Thank you very much for this opportunity. And this is also something that, as ma'am was saying about less number of third party, this is something we can probably keep looking at a for our patients. Thank you so much.